Dr. Geddes, or unarguably. Is that a word? I don't know. It's been a long day. How many conferences now is this, Amy?
I think this is my third.
I think it's more than that. Don't you think? Anyway, Amy is definitely part of the 11Q family. So Dr. Geddes is a professor of pediatrics at UCSD and practices out at Rady Children's Hospital. In addition to taking care of children with blood disorders and cancers, she has in the past performed very important research on bleeding disorders. Her emphasis is on defects in platelet development, and she's actually seen a number of patients here in San Diego with Jacobson syndrome, at least one of which is here in the room right now as we speak. So it's a great honor and pleasure and privilege for me to welcome again Dr. Geddes, who, as you know, is talking about a subject, the knowledge from which can literally have life-saving implications for your children. So I will ask you to be my legs and grab your bottle of wine, kindly provided by Sopizio family. You have to wait till after the talk. That's true. I'll request that, although it is after 5 o'clock now. So. Almost.
Not yet. Not yet. All right. I just talk a little bit about bleeding and thrombocytopenia in general and management in general, and the talk is supposed to be fairly informal, so leave lots of time for questions. So everybody always has lots of questions. So, as you know, Paris-Trousseau syndrome is an inherited disorder and is a constellation of symptoms, only one of which involves low platelets, and not everybody has low platelets, and is due to the deletion of the terminal portion of chromosome 11q. And why does this deletion matter for platelets and megakaryocytes? And it's because normally in this chromosome, within the deleted portion, there is a gene that's important for platelet development. So normally everybody has 2 copies of each gene, and 1 from each parent. If 1 copy is lost, then there may not be enough of the protein product for the cell to work normally that the gene produces. And even if it can work normally, maybe even if the cell can work normally, if there's a problem with the remaining copy of the gene, then that can be a bigger problem than there would usually be. And a deleted region of the chromosome usually contains many genes, so that's why people with this syndrome that involves a deleted chromosome can have variation in their expression. And so the gene within the 11q portion that's deleted that we think is responsible for the defect in platelets is called FLY1. And it's known to be essential for megakaryocyte and platelet development. So if you delete it in a mouse model, then they have severe problems with thrombocytopenia. And it also is important for red cell development as well. And so this is just a little schema shown here where we talk about blood cell development. So normally blood cells all derive from a common precursor called the stem cell. And then they go through a series of differentiation steps where they ultimately will become this precursor here, which will lead to the production of red cells, as well as the cells that make platelets, which are called megakaryocytes. And FLY1 is an important gene that acts right here in this differentiation step between megakaryocytes and platelets, or megakaryocytes and red cells, and it's critical for the development of megakaryocytes. And if you don't have megakaryocytes, then you have trouble making platelets. So what are megakaryocytes? Megakaryocytes are large cells in the bone marrow. You can see here in this picture that this is a megakaryocyte, and these are your other humble blood cells, which are much smaller. And the megakaryocytes are so big because they need to make platelets, and they can make up to 1,000 platelets per megakaryocyte. So each megakaryocyte has a large job. Let's see if the movie works. No, it's not going to work. So this movie will show you a megakaryocyte basically dissolving. Here are the proplatelet processes that are starting to develop, and this megakaryocyte will dissolve into processes, each of which form platelets. And so that's how in the bone marrow your platelets are made. And how do platelets stop bleeding? Well, we know that platelets function in a number of ways to stop bleeding. In the first step, they do what we call adhering to the site of vascular injury. So when the blood vessel is disrupted, in this cartoon you can see the normal cells lining the blood vessel are disrupted, exposing the collagen below. And then this results in the process where the platelets actually stick to this area of disruption and start the process of clot formation. And important in this process of adhesion is something called von Willebrand's factor, which is a protein in the blood that helps to serve as the glue between the platelets and the collagen. And then receptors on the platelet surface called GP1B and GP2B3A, and those are all important in participating in this reaction. Once the platelets start to stick to this exposed collagen, they can become activated, and then they recruit other platelets to form a platelet plug or a clump, and that's kind of like the early blood clot. And important in this process are specific granules in the platelet. So the platelet will become activated, it'll release its granules, it will change shape, and this recruitment of other platelets again forms the platelet plug. And aspirin is really important in inhibiting this process. And we use aspirin in many different types of situations where you're trying to inhibit platelet plug formation. And then once the platelet plug is formed, it can recruit other clotting factors from the bloodstream to form the final blood clot, which will ultimately lead to healing of the blood vessel. And so again, platelets are really important for stopping bleeding, and as you know, when you don't have enough platelets or if they don't work properly, you can have increased bleeding symptoms. So what about the platelet granules? We talked about the granules. They're important for the second step process of aggregation, where we recruit other platelets to form this platelet plug. And the granules inside the platelet generally have two types. There's alpha granules and dense granules, and they both function to release these substances that promote this process. And in the lab, we can actually test platelet function by stimulating the platelets with different things that will either stimulate release from alpha granules or dense granules and measure how well the platelets stick together in the test tube. So it's one way we can look at platelet function. So how do we test platelets? When somebody comes and we think they're bruising, how do we assess whether we think that there's a problem with their platelets? Well, first thing we do is we count the platelets, and so we get a complete blood count, and we actually see if the platelet number is normal. So the normal person has a platelet count between 140 and 250,000. This is well above the number of platelets we think that you usually need to stop bleeding. If somebody's platelets work normally, we think that they don't usually start having symptoms of bruising or bleeding until their platelets are less than 50 or even less than 20. But the normal range is 140 to 250, so if you're less than this, we say you have low platelets. And we can also, in the blood count, determine if there's been any consequences of chronic low platelets or chronic bleeding, and this could be, for example, anemia, iron deficiency anemia, somebody who's had low platelets for a while. In addition to seeing low numbers of platelets on their smear, we may also see that they have anemia or small red cells, which suggests that they may have developed iron deficiency. We can also look at the platelets on the smear and see if they look appropriate. Do they have normal granules? Are they normal size? But sometimes people can have normal platelet counts and they still have bleeding, or they have bleeding that we wouldn't expect at a platelet count that's higher than what we think that they should bleed at. So for example, somebody comes to me with a platelet count of 100,000 and a lot of bruising, I wouldn't expect that they should be bruising with a platelet count of 100, because as I said, often people don't have bleeding until their platelets are less than 50 or less than 20. So in that situation, I might suspect that maybe their platelet function is not normal. So platelet number and platelet function can be different. And functional studies can be tricky because most of them it's difficult to distinguish whether in the tube whether the platelet function abnormality is because their platelets are low in number or whether they don't work well. So it's easiest to assess platelet function when the platelet count is actually relatively normal. And platelet function is also very sensitive to medications that, or even foods that somebody might be eating. So if you've been taking aspirin recently, as we know, aspirin will inhibit your platelet function, and that will result in an abnormal test. But there's a couple of different ways we can look at platelet function. The easiest one that people like to order frequently is called the PFA, or Platelet Function Assay 100. And it's basically you take whole blood and you run it through a little cartridge that's coated with collagen to sort of simulate the broken blood vessel in a tube, and we just see how long it takes for the blood to clot in that setting. It's very quick, it's very easy. It's not all that useful, but it sometimes is done as a first screen as to whether there's a problem with platelet function. The second assay that we often do is we can measure platelet aggregation in the tube, as I said, by stimulating the platelets with different chemicals that might stimulate the different types of granules to release. And then you can see how long it takes for the platelets to aggregate and clump together. And this is a pretty sensitive test, and it can be very helpful because not only can you measure how long it takes for platelets to aggregate, you can see which pathway, which specific problem in aggregation somebody's platelets might have. But the problem with this assay is that not every lab does it, and it has to be done fresh. So basically when we said people do platelet aggregation studies, they have to come to the lab at 8 o'clock in the morning, we draw their blood and we put it on a fan and we run it right over to the university so it can be processed within like an hour. So not everybody can do that. If you don't have a lab near you that does it, it's hard to get the study done. It's also somewhat tricky, so there can be lab-to-lab variation. If you get the study done, it may be slightly different at one lab versus another. So it's a good test, but it has its limitations. There's another assay called the ADP release assay, where you can measure specifically the release of the dense granules, one of those granules, and that's a useful test. Very limited labs do this. I'm trying to send it right now on one of my patients, and the only lab that does it is in Philadelphia, and so far it's taken me 3 months to try to get this lab sent. So it's also difficult to get. And then finally, there's something called a thromboelastogram, which is another whole blood assay where you can measure the dynamics of blood clotting in whole blood, and it looks at all the processes from this platelet sticking together to the recruitment of the coagulation factors. So it doesn't really specifically look at platelet function, but it can measure the contribution of platelets to the whole blood clot. So there are different tests we can run to try to assess whether somebody might have a problem with their platelet function. We can also look at the platelet structure. So we can either look at the platelet under the microscope, not only the regular microscope, but a special microscope called the electron microscope, where we can really in high definition see the platelet granules and whether they're normal in number or shape. And we can also look at the surface expression of the proteins on the platelet surface that contribute to that process of platelet sticking. So what are the drawbacks for platelet function testing? Well, as I said, it's not always available. There's a lot of tests, but sometimes it's hard to get them, and they're not well standardized. Sometimes there's not a lot of recommendations as to what to do for specific abnormalities. And again, it's very difficult to assess platelet function in somebody whose platelet count is also low. And so sometimes it's difficult to determine. And so sometimes you just have to take a gestalt. This patient is having bleeding with a platelet count of 80, their platelets must not work normally. Sometimes that's kind of where you're limited to. And the other problem for small children is that platelet function testing can take a large volume of blood, and sometimes that's prohibitive. So for example, platelet aggregation studies, they usually tell me they want 20 mLs of blood. If somebody weighs 10 kilos, that's usually more than I'm allowed to draw. And so sometimes you run into that problem. So like I said, sometimes we just sort of do this as a common sense approach as to whether we think that there's probably a problem with function, or at least we need to assume that there might be. And so how are the patients, the platelets with Paris-Trousseau syndrome different from normal platelets? So we know that, that patients with Paris-Trousseau syndrome, their platelets have abnormal granules. So we talked about the importance of granules for platelet aggregation, and this is an electron microscope, a picture of a normal platelet on this side. So you can see these small little granules here. Those are the alpha granules, and you can see these dark granules. Those are dense granules in this normal platelet, and then you have this kind of this reticular system of pouches in between. So this is a normal platelet. So this is a picture of a Paris-Trousseau syndrome platelet under the electron microscope, and instead of having these small dispersed platelets, they have this big glob of a granule right in the middle. And so that's typical. They have this fused alpha granule that presumably doesn't function normally. So we believe that Most patients with Paris-Trousseau syndrome may have abnormalities of platelet function. We know their granules aren't normal. And in limited studies where people have tried to look at platelet function, they found differences in patients with Paris-Trousseau syndrome from normal platelets. Bleeding times may be prolonged in patients even when platelet function is normal. So again, that suggests that platelet function is problematic. And overall measurements of platelet function can be normal, but then there could be subpopulations of platelets where there are these abnormal granules that are not normal. So again, it's been tricky to measure. There's conflicting data, but the overall gestalt is that that there's a deficiency of there's an abnormality of platelet function, and it's based on an abnormal population of granules in the platelets. So the natural history of thrombocytopenia in patients with Paris-Trousseau syndrome is that they may have low platelets, and if they do, it's usually worse at the time of birth. And so again, the platelet counts can be as low as 10 to 20,000, in which case we usually have to give platelets. And again, reference points is that the normal counts are more than 140,000. But within time, usually platelets get somewhat better and may improve to either normal or near normal levels. But that said, some people still tend to have easy bleeding symptoms, and this could include easy bruising, frequent nosebleeds, prolonged bleeding or oozing after a dental extraction or removal of tonsils, or in girls, heavy periods that are longer than you would expect or have more bleeding than you would expect. And so these are all typical symptoms for somebody who either has low platelets or maybe their platelets don't work that well. So how do we deal with these symptoms? There's a number of different approaches. Simple things are oral medications that you can take, and this might include a medicine called Amicar. So Amicar is a medicine that works it doesn't help you to make a clot, but once you make a blood clot, it helps to stabilize that blood clot until the tissue underneath is healed. So Amicar is most useful for dental procedures. So if you've had a tooth pulled, or maybe a nosebleed, or you fell and bit your tongue and it won't stop oozing, Amicar is really good for that. It can also be used post-surgically for like wisdom teeth or tonsillectomy. We often prescribe it in that setting. It can be used as a mouthwash, so that it comes as a liquid, and if the bleeding is sort of in the front, like your tongue or one of your teeth in the front, then you can actually swish it and spit it out. You don't have to swallow it. But if the bleeding is somewhere in the back or in your nose, then you need to swallow it. It also comes as a pill if you're planning on swallowing it and you don't want to take a liquid. It's a little tedious. It's 4 times a day, and you usually have to do it we usually recommend you do it for like 7 days, because you want to keep that clot in place until all the healing has happened. But it can be very effective. For girls with heavy periods, the standard recommendation is the most effective therapy is probably oral contraceptives. So estrogen oral containing contraceptives will, first of all, inhibit the periods so you can have fewer of them. And then if taken consistently, they usually shrink the lining of the uterus such that when the bleeding does occur, it's not as heavy. And so that can be very helpful for girls with problematic periods, especially if they're leading to iron deficiency anemia or interfering with their activities. DDAVP or Stymate is another medication that can help patients who have normal numbers of platelets but a problem with platelet function. And it's not really clear how this medicine works, but it seems to improve platelet aggregation, probably by increasing the platelets binding to that von Willebrand's factor that's important for that first step of platelet clotting. It comes as an IV form, which is best used in small patients, but it also comes in larger patients. It comes as a nasal spray, which is convenient to use at home. So if you have somebody with a lot of bleeding and you know that Stymate works well for you, then that can be something you can use at home. And lastly, if you have bleeding that's significant or not responding to those above procedures, or you're having a major surgery where you're just anticipating that you're going to have bleeding and you don't think these other therapies are going to cut it, you can actually give platelets. And of course, if your platelets are low, these therapies aren't going to work, and you're going to have to give platelets. Platelet transfusion, again, can be very effective. It works. You're giving platelets with normal function. The half-life of those platelets is about a week, but that varies from patient to patient. So depending on what type of surgery you're having or how long you need your platelets to be higher, you may need additional transfusions over the period of time. It's associated with the risks of transfusion. So if you're having a minor procedure or minor bleeding and you want to avoid transfusion, you might want to try these other therapies first. But that said, when you need platelet transfusion, then that's the best treatment if you're having bleeding that's not due to either a lack of platelets or a problem with platelet function. And that's really all I wanted to talk about for my part, and I've tried to answer questions, because usually at this time of the day you're probably tired of having people talk to you and you'd rather have your questions answered. So if you have any patient questions about platelet function or medicines to treat platelets, happy to take them now.
We have, let's up with the live stream. Do we have any questions first? Do you have any questions on the live stream? We just kind of thought so.
I'm from Brazil and I have a daughter 8 months old that has JS. I've underwent 2 surgeries. One had not been completed. The reason was a very heavy bleeding. But just going into blood tests, which did not identify the anomaly. Now doctors conclude that must be whatever syndrome has been made. The question is there a normal procedure so that it is by deduction that he has that syndrome?
So I'm sorry, what was the syndrome? I missed the name of the syndrome.
I don't know how to pronounce it. Yes, thank you.
Oh, so I think if I'm remembering correctly about this family, the child has Jacobson syndrome, had some kind of craniofacial skull surgery, and as a lead-up to that, had some kind of testing which included showing, I think, normal platelet count, and nothing came up abnormal with the platelet function testing, but still had catastrophic bleed that prevented them from being able to complete the surgery. And I've heard this kind of story more than once, so maybe can you comment on the...
Yeah, I mean, I think our platelet function testing is somewhat imperfect, as I tried to elicit, and I think the data for there's limited data as to what the specific functional abnormality is in Jacobson syndrome platelets. And so sometimes, like I said before, I think sometimes you have to go functionally what people have done. And so if you're bleeding with a normal platelet count and you don't have another explanation, and it's worth looking for there's other contributions to bleeding, there's other contributions to bleeding problems. There's deficiencies in von Willebrand's and there's factor deficiencies. So it's worth looking at all those things to make sure that you're treating the bleeding correctly, because sometimes the correction would be different depending on which factor is the problem. But if you've done a thorough evaluation and I think that we have these tools available to us, and like I said, the platelet function assays that we have available to us are not perfect. And if you can't identify another source of bleeding with this diagnosis, I think it's reasonable to assume that you might have a problem with platelet function and treat it as such. And again, a lot of the things we do, like Amicar and DDAVP, those aren't necessarily specific for platelets. They work with platelet dysfunction, but they also treat other things. Amicar is useful for lots of type of bleeding, so we use it with our patients with hemophilia and von Willebrand's and platelets. So you can use that in any setting. You don't have to know where the bleeding defect is to use some of these things. But platelets per se are not going to help you that much if your problem is not with your platelets. So it's important to look at the other things.
More live stream questions?
Okay, yeah, there's 2 more. Do you know of any institutes, can you say it, interstitial deletions have platelet issues?
are there any patients with interstitial deletions that have platelet issues? And the answer would clearly be yes if it involves FLI1.
Yeah, I think at this point, we think that the primary issue is FLI1, so if the deletion includes that, then they would be at risk for the platelet issue.
And one other one, I'm not sure if pronouncing these words here. Have kids that have undergone surgery for strep illness had issues with bleeding, do you need to address BTS for all surgeries?
So I think I always keep it in mind. Certainly, there's some surgeries that are bigger risks than others, but in my mind, it's always good to have what your bleeding plan is. You might not think you need to do. You might think, okay, my bleeding risk is low. I'm going to go into the surgery without any. I'm not going to give platelets or other therapies. But in my mind, I think, well, but if I have bleeding that's more than I expect, this is what I'm going to do. So it's good to have a plan anytime you go into surgery of if you encounter bleeding, what you're going to do. And then be ready for that.
Okay, and are there any disadvantages of taking platelet transfusions?
So platelets are a blood product, so they carry the risks of other blood products in terms of the potential for transmission of viral disease. Most blood banks screen very carefully for viral diseases and other blood-transmitted diseases, but again, screening is not perfect, so there is always that possibility. People can also have allergic reactions to platelets, so it's one of the most common reaction we see to a platelet transfusion would be an allergic one, and usually easily managed with Benadryl, but can occasionally be more problematic than that. And then platelets are also stored at room temperature. So when you collect platelets from somebody to transfuse to somebody else, as opposed to red cells, which are refrigerated, platelets are stored at room temperature. And because of that, they are prone to bacterial contamination. So if you're collecting platelets and you get some bacteria from the skin in the contaminant, again, they guard against this and they screen for it, but there is a risk that there could actually be bacterial contamination of the platelet product. So these things are rare, but those are the primarily, except for the transfusion reactions, which are not all that rare, but the infectious risks are rare, but they are the primary reason we try to avoid blood transfusions, blood product transfusions if we don't need them.
What about antibodies to platelets?
And if you get transfused frequently, you can develop what we call alloimmunization, where we can recognize something on that donor platelet that's different than your own platelets and raise an antibody to it, so that in the future you would have a lesser reaction to platelet transfusions in the future. And so usually it's in somebody who's been transfused over and over again, frequently, but it can occur at any time.
Okay, and one more question. Our head HEMA is recommending the use of a helmet for preventive protection in case of falls for a 15-month-old who has platelet dysfunction. Do you recommend, and if so, do you have a helmet you like?
So I think the helmets are a personal decision in between the pediatrician and the children. I think it depends on how many falls you're experiencing and what your concerns are. Often our patients with bleeding disorder and hemophilia, we don't routinely recommend helmets, but on an individual basis, I can't say that it's not the right thing to do. And I don't have a specific recommendation for one helmet or another.
Hello.
Hi.
Thanks again for being here. My question is, my husband and I are both O positive. Mm-hmm. All three of my sons are type O negative. Now, I understand, genetically how that can work. I think it's weird, but so it worked out that way.
Statistics.
My son had to have a platelet transfusion. And again, I understand why they couldn't take ours because we're both positive. Mm-hmm. But they were basically, my hematologist, I felt, kind of dismissed me about my concerns about the general population's blood and how I, was really anxious about him getting this transfusion. And she said, my father-in-law is O negative, and so he wanted to donate. And she said, oh, well, that far removed, it really doesn't make a difference. And I felt like it made a difference in my peace of mind that I know he's healthy, he doesn't do drugs, he doesn't, engage in whatever. Is that normal that a hematologist would prefer to take it from the general population? Is there some reason that it could be worse to take it from a relative who is not a parent or a sibling?
So statistically, there's not a benefit to donor-directed blood when you look at the safety. From an individual perspective, you can't make any judgments about anybody's families one way or the other, but from a statistical standpoint, there isn't a safety difference, because I think they talk about the rationale being if you ask a family member or friend to donate, and they have something that they wouldn't want to disclose to you, they may feel pressured into it, whereas if I'm donating to the blood bank, I'm only doing it out of altruism, and there's no particular pressure or gain for me to do it. I don't get paid, I don't have anybody talking me into it. So I'm not saying that obviously in everybody's family they feel that their family members are safe, but from a statistical population standpoint, there isn't a difference. And so usually if we're thinking about somebody where we're not really, the problem with platelets usually is it's difficult to coordinate when you need the platelets with when to donate.
The surgery was 2 days after Christmas.
Yeah.
It was a huge problem.
Yeah, especially if it's not something scheduled. If it's something scheduled, it's easier to coordinate and you can usually work it out, but if it's an unpredicted, oh, today my platelets are low, I want to give donor-directed platelets, it's hard to have them on the shelf, because as I said, they usually have like 4 or 5 days of shelf life before you have to throw them away. And we really hate throwing away platelets because they're in desperate need, so we also hate having people donate platelets and have them get pitched because we couldn't match it up with when the person who is supposed to get them got them. So I think those are the sort of practical reasons why sometimes people don't push getting donor-directed platelets, but on the other hand, if you can work it all out, I have no problem with it either. The time we really try to avoid a family member donating is when there's a question of a bone marrow transplant. So in some of our patients with other hematologic problems where we may think they're a candidate for bone marrow transplant, if that donor may come within the family, we don't want them exposed to blood products from within the family, which might risk that they would develop an immune reaction to them. But that would probably not be associated with the situation.
Okay. And this is kind of just specific to him, but as a type O negative, what kind of platelets can he accept? Is it different than a regular blood transfusion?
It's a little different than the regular red blood transfusion because the platelets don't have the same antigens on them that you're worried about with the red cell reaction. There is plasma, so there is the capacity for antibodies in the platelet product so you don't want antibodies in the platelet product that would react to his red cells. But you don't have to worry so much about red cells in the platelet product breaking down if he has antibodies to them. There's a few red cells in there, so it's enough. It's enough to break down a little bit, but it's usually not enough to cause the same problem that you would get if from a red cell transfusion.
Thank you.
Yeah.
I'm not 100% sure I asked this last time. I might have, if it was within the time period.
Hopefully I have the same answer.
We had a situation most recently where I had to go into her medical records and find out the information. And I wanted to know if there was a general preference or maybe a developing protocol in relation to the immune problems that they have with the chronic infections and the necessity of platelet transfusions before, like for example, my daughter having an open and drain on a cyst, and the necessity or preference or protocol of whether or not to use irradiated cells compared to non-irradiated cells. Mm-hmm. And so when I asked that question, because she had been chronically ill prior to this specific situation, if it was time for something like that, I kind of got a blank. And so prior, we had 2 other episodes where irradiated cells were used in the transfusion, but then this time they're like, no, I don't think so. So I was uncomfortable with that and thought maybe there might be something.
So we typically use irradiation for radiation of blood products for patients that we think have a defect in their immune system. So if you have a normal immune system, then you don't necessarily need to irradiate the blood product. It doesn't prevent, the radiation doesn't prevent the cells from carrying infection. The best thing that we do for that is we do something called leukapheresis. We take out the white cells. Those are the things most likely to carry infection. But the radiation is purely to inactivate white cells that could if your own immune system is suppressed and you get a transfusion that has active white cells, they could, in theory, cause something called transfusion-associated graft versus host disease, and that's what the radiation is for. So if you have cancer, if you have an immune deficiency syndrome, if you're getting medicines that suppress your immune system, we favor irradiated blood products, and if you don't, then that's not necessary and probably shortens the lifespan of the platelets. So if you really don't need them, it's probably better for you not to irradiate the platelets, because then they're going to last longer for you and do you more good. And so that's how I would make that judgment.
I actually have a few questions. They were emailed to me from family who can't be here. Her first question is, I'd like to understand the bleeding protocol a little more regarding the restrictions on using ibuprofen. What effects does it have on the platelets, and are the effects temporary or long-term?
So ibuprofen and all its relatives, that's Advil, naproxen, Motrin, all sorts of what we call the non-steroidal anti-inflammatories, as well as aspirin, can inactivate platelets. And aspirin is the worst. Aspirin will inactivate your platelet for the life of your platelet. That's why we give it to people that we think have risk of heart attack, because it keeps your platelets from sticking to those arteries and causing that little plug that gives you the heart attack. So aspirin's the worst, but ibuprofen and all those medications will decrease your platelet function to some degree. It's more temporary than aspirin, and it's not as significant as aspirin. And if you have a normal platelet number and you don't have a lot of symptoms and you're not going to surgery, I don't think there's anything wrong with judicious use of Motrin and ibuprofen for fevers or pain or things like that. But I would be cautious of using it right before or after a surgery, especially if there's a concern that your platelet function might not be normal or your platelet number is not normal, because it could worsen your bleeding tendency. So usually we recommend, if you're just taking it for fever and pain, and Tylenol works, the Tylenol is the best thing because it's not going to affect your platelets. But it's a relative precaution about using Motrin and those medications, but again, not absolutely forbidden. It just depends what the context is.
Okay, and her next question is, can Paris-Trousseau impact the ability for a female to be pregnant, carry a child, and give birth to a child? Would the bleeding risks be too high?
I haven't had that question come up before. I think that it's probably an individual basis, because everybody's bleeding risk varies, but even our patients with bleeding disorders, we don't restrict, we don't tell them that they can't get pregnant. They may need an obstetrician who's aware of their bleeding problems and may have to have some interventions especially around the time of delivery, to make sure that they're safe. But I don't see a specific contraindication related to that.
Okay, and her last question is, can Paris-Trousseau be inherited independently from Jacobson syndrome? For example, if my daughter had a child if my daughter had a child and that child did not inherit Jacobson syndrome from her, could the child still inherit Paris-Trousseau?
I think they should be the same, because they originate from the same chromosomal change.
Isn't there something called gray platelet syndrome?
There's a lot of other disorders of platelet function, and that are different, but there's a list of 10 to 15 different types of inherited thrombocytopenias we know about, or platelet function problems we know about, but specifically, these two things should travel together.
So, question over here. As far as we know, my daughter doesn't have the Paris-Trousseau. She has a regular platelet count and hasn't had any bleeding problems or anything like that. So since she's okay now, will she have that in the future?
I wouldn't expect that it would change over time. I wouldn't expect that if she isn't having a problem that she would have one in the future.
But can I just chime in for a sec? I think it's a really important point to make, that just because you don't think your child has Paris-Trousseau syndrome, I think we have to make the assumption that every child with Jacobson syndrome does have Paris-Trousseau syndrome. The only difference is the degree of severity of it. So I don't know if she's had any kind of major surgical procedures, but I think,
there's variation, and I think the most important take-home lesson, and feel free to chime in, Amy, if you disagree, is assume your child is at risk for bleeding until proven otherwise. That's not to say that your individual child may not be, but for example, that family in Brazil, and I think there was another similar situation, you have to go into that procedure when you're at a time of risk for bleeding and be prepared and be proactive. And your child may be lucky. And I hope eventually we can learn what might distinguish your child from others, but for now we have to err on the side of assuming that every one of your children is at risk. Does that make sense?
Yeah, would you recommend that we have her tested to?
You better ask her. Yes, I would. I mean, maybe they just haven't done the right test. Maybe there isn't a test to identify.
Yeah, I'm not sure there's a great test, and so I think that's part of the issue is it's not a great test. So I think that it's if she isn't having problems, that's great. I think you can go into your procedures and not do anything ahead of time, but I think again just having an idea of what you would do if there was unexpected bleeding is always a good idea.
With illnesses,
Excuse me?
any of that?
Excuse me?
If they're compromised by an illness or something, would that be a factor?
It doesn't so sometimes when people are sick, their platelet count can vary. So for example, if your platelet count's normally 100 and you get sick, then sometimes it can go down to 60 or, it can change. I wouldn't expect the function per se would change related to an illness, again, unless you're taking medications that affect your platelet function.
My question was pretty similar. My daughter tested negative for Paris-Trousseau, and I was wondering how, should I trust that?
What was the
Has there been
test?
Any issues? I don't know exactly what the test was. I mean, we went to, the Romans, we went to the same place they did, lived by each other. And they tested your daughter positive, right? And they tested our daughter negative.
Yeah. But typically, I think.
I'm assuming they have,
Typically, I think they can look for abnormal granules. They can do the platelet function testing that we talked about. Those are pretty standard assays that they can do. And so if they look normal, and she has, I think the key is how much bleeding symptoms is she's having. Because to me, that's the most important thing. If they're having more bleeding than you expect, then I don't care what for a given platelet count. Then I don't really care what the test says.
So the test may not be, because the thing is, she hasn't had bleeding issues. She's had a couple surgeries and things like that. No bleeding issues being told. But yeah, I still feel like, well, she was born with really low platelets and they still run low, but they're like 112 or something. They're not really low, but they're always.
Yeah, so if she went into a high-risk surgery, and again, it depends what she's having done, but say they tell you that she's supposed to get her tonsils out. I would still be cautious because tonsils is a procedure where you can have a lot of bleeding. Even normal people with normal platelets and normal function can have bleeding. And just say, okay, I think she's going to be fine, but just in case, this is what I'm going to do if she has bleeding more than I expect, and that's always worthwhile.
Would you recommend having her tested again so that there's something on file, or do you think they would probably find the same thing?
I don't, unless it would be helpful to know what tests they did to be able to say that for sure, but at the moment there doesn't seem to be any reason. I mean, she's not having symptoms, and like I said, I'm not sure I would do anything different depending on what the test said. I would still say if she's going to have a high-risk surgery, I would just have a bleeding plan in mind, just in case. It doesn't hurt.
My daughter has hypoplastic left heart, and
That's your question.
we were originally started her on aspirin, but when she was given the aspirin, she had increased bruising and all that. She did have Paris-Trousseau. Her function is abnormal. Her quantitative number is she's usually around 150. But we do know that it doesn't function properly. So and I'm glad you're up there, Dr. Paul, because
Don't run away, though.
it's kind of a panel.
That's right. That's a great question, what you're going to.
Between the stroke issue and maybe, this was the first time I had heard that ibuprofen might be an alternative to aspirin, the aspirin therapy that they normally assign after hypoplas. What are your thoughts?
Well, so from the hypoplastic left heart standpoint, or in general, when you have the Fontan, you are at risk for clot formation. So our standard of care is at least to anticoagulate with aspirin. We actually anticoagulate with Coumadin at least for the first 6 months, and some centers actually put them on lifelong Coumadin. So it's a little bit variable what the specific protocol is, but in general, we almost always will have some anticoagulation. But then you have to balance that against the fact that, okay, if you're anticoagulating someone that already in effect is, I don't want to say anticoagulated, but is at higher risk for bleeding, you know, could you be too aggressive by superimposing a pharmacologic intervention on top of, you know, the inherent bleeding problem from the platelets? So there was actually a paper written about that was published recently, and I think, you know, the bottom line is I think you have to assess each case individually. So I think when you said that Faith, when she was put on Coumadin or aspirin, I can't remember.
It was aspirin.
And
it was like half a baby aspirin.
Yeah, and if she was really having a lot of bruising, that would probably tell me that's too aggressive, because if she's having a lot of bruising, that probably means she's at risk for other more serious bleeding complications as well. But again, you have to weigh that against the risk of, could she be forming clots? And I can tell you, if you clot off your Fontan, you're dead. Or if she's got a fenestrated Fontan and she forms a clot, she could have a massive stroke in her brain. So there's not an easy answer. And Amy, do you want to chime in?
I mean, I guess I would say you have to, it's a risk and benefit assessment, and I would actually think that if your cardiologist thinks that aspirin's really important, I would probably tolerate some degree of bruising. But, you know, again, you have to decide, and then you have to be careful if she's having, if she's having surgery, again, she'll have to hold those things, and again, aspirin permanently affects the platelets, so if she did have bleeding symptoms that actually needed some kind of reversal, again, you need platelets for that usually.
So for as far as how the Fontan goes, would ibuprofen be maybe a less aggressive treatment?
Yeah, but I don't think there's much data for using it in that scenario, so I think you're either going to use aspirin or you're not going to use aspirin.
Yeah.
I don't think there's much, I don't think there's much data to know whether ibuprofen is adequate in that setting.
Okay, thanks.
So my question is there any hope that someday, by the use of stem cells, that we could reverse that or regenerate the low blood platelet count?
I guess in theory you could use stem cells and replace the blood with new cells that would then make normal platelets. But I think at least at this point, the consequences of stem cell transplant and all the risks inherent, and I don't think that this would be an indication. I don't think the risk benefit would merit that. But maybe in the future we'll get better at. Or stem cell, probably more likely if we can actually correct stem cells. So I think the holy grail is that you can take somebody's own cells out, fix them, and stick them back in, and then correct the stem cell defect that way. Again, it wouldn't be good for the whole body, but we could theoretically probably address the blood cells in that way. So we're not there yet, but maybe in the future.
Okay, we have one live stream question. Which of the anti-inflammatory drugs can be used with children with Paris-Trousseau?
So most of the anti-inflammatory medicines will have some effect on the platelets. The one that has anti-inflammatory activity that doesn't seem to affect bleeding, or at least not very much, is Celebrex. And so if you needed not just pain or fever control, like you can get that with Tylenol, if you actually needed the anti-inflammatory effect, then Celebrex is probably the best one.
I wanted to see if there was any information available with the Paris-Trousseau syndrome on any other Jacobson syndrome patients that might have seizure disorders and any complications because of that, you know, or the potential for brain bleed.
So the question is, does the seizure increase your risk of having a hemorrhage?
Or Paris-Trousseau, if you already have an underlying seizure disorder.
So probably it's usually the bleeding that triggers the seizure and not the other way around. And so I don't think the seizures per se will cause bleeding. If you have a seizure and you fall and you hit your head, then that's obviously going to be a risk. But I don't think the seizures themselves are going to increase your risk of having a bleed.
Does Paris-Trousseau create an extra risk for brain bleed?
If your platelets aren't working as well, then yes, you have an increase of bleeding anywhere, and that's one of the places, maybe not so much that it's more likely, but the consequences are so significant if you have a bleed inside your brain, that those are the ones we worry about the most. And so again, we're cautious about if children fall and hit their head and we know that they have a bleeding disorder of any sort, that's one of the things we're careful to assess, is if they've had any bleeding problems.
What about underlying medications used to support the seizure disorder? Would it have any contraindications with the seizure disorder?
So some of the seizure medicines will have can have low platelets as a side effect. Keppra is usually not too, Keppra I don't usually see that problem. We use the Keppra in a lot of our patients getting chemotherapy, and it's usually not an issue. Yeah.
Okay, we have another live stream question. Have either of you seen a 11Q patient with a storage pool disorder and not Paris-Trousseau?
So it's been described. Yeah, the problem with the dense granules, it's been described.
I'm not sure what the difference is.
So I think the classic Paris-Trousseau is the fused alpha granules, and the storage pool is typically the dense granules. But I've seen it published. And again, you can do some of the special assays. They're like the ADP release assays specifically, and look at dense granules, or the electron microscopy can tell the difference.
All right.
Huh?
I think it's a wrap.
All right, thank you.
Do you think there's going to be some sort of protocol for the bleeding because it's not something
A protocol for what? I'm sorry?
you have the bleeding protocol for Paris-Trousseau. You have the bleeding protocol for Paris-Trousseau, but what about including a line item for something of how that could pertain to, children that may be having seizures that's not considered during their course of treatment when they're brought in the crisis? Because our protocol is if she has a seizure 1 minute, we have to go in. And so when I'm going in, I'm worried about stopping a seizure, not thinking of the potential of Paris-Trousseau could complicate that.
Well, I think like Amy alluded to, I think the main thing, seizures, I think in and of themselves are not likely to cause a bleeding episode unless, like she said, you fall and hit your head or something. So I don't think there's anything more that would have to be done to address that. I think it's very unlikely that Paris-Trousseau is going to cause, I think it's very unlikely that seizure is going to cause bleeding. It's certainly possible in a catastrophic situation that bleeding in the brain could cause a seizure, though. What's that?
At least remind them to look and maybe re-verify with the CAT scan, not just say, oh, you had a seizure, it stopped now, go ahead and go home.
Well, okay, so I would say for sure that any child with Jacobson syndrome who has a seizure without any known explanation for it should definitely get an imaging study of the brain to make sure there's not an acute bleed. Do you agree with that?
Especially if it's a new seizure. I mean, if you're chronically prone to seizures and you're having seizures all the time, you don't want to scan every single time. That's not.
No, if it's a new presentation.
But if you've never had a seizure before, first-time seizure, people usually do some kind of imaging. Often MRI gives you more information than a CAT scan. CAT scan's the quickest, so if you're worried about a bleed, then that's probably the thing you want to do in the emergency room. But most patients with a first-time seizure, they'll do some kind of imaging study. Again, once it's a chronic problem, you don't want to image every time, unless there's something atypical about the presentation.
All right.
Thank you very much.
Based on the screams, I think people are supposed to be picking up their kids next door. That was actually supposed to happen 15 minutes ago, and I forgot to make that announcement before. But
Hi, how are you?
so thanks again to Amy for an incredibly important and insightful talk.
Just for tomorrow, Lindsay wanted to remind everyone that the SIB shop begins at 9, but the conference still does begin at 8:30, so you have to be here on time for that. And also tomorrow we're having pizza for lunch, courtesy of Dr. Paul, adjacent to the hotel here in the park. We can't do it on the hotel property. It'll be right there, though, on the park. Okay? Thank you.
Great. Does anybody have any other questions, concerns about anything? All right, have a good evening.